Good evening, dear friends. Welcome to our session, Sunday Critical Care webinars. So today the topic is acute heart failure or acute decompensated heart failure, as you may call it. So today we have a very eminent speaker with us. Sir was also my teacher at AIIMS. Sir was the former professor of cardiology at All India Institute of Medical Sciences, Professor Sundeep Mishra sir. Now he has joined AIIMS University, Rajasthan, Jaipur, and he is the president and vice chancellor there, and also the director of the Institute of Cardiology. Sir has also held the esteemed post of the editor of Indian Heart Journal, and has been a very eminent teacher in AIIMS, and of course now. So it will be indeed a pleasure to hear from him. Thank you, sir, and over to you.
Thank you, Dr. Tapesh, for calling me here, and welcome everybody to this series of webinars. I do hope it will be useful to you. So, can I share my screen?
Yes, please share your screen, sir.
Okay. Can you see my screen?
Yes, we can see and hear you, sir. Please start.
Okay.
Full screen, I think. Just make it full screen.
I'll make it. Okay.
Yes, sir.
This is fine.
Yes, yes.
Okay, good. So, friends, what I'm going to discuss today is advanced acute decompensated heart failure, 5 marriages and 2 funerals. So the way I'm going to do it is by clinical cases. So I will basically show you 7 clinical cases that will bring out all the nuances of ADHF or acute decompensated heart failure, and I hope will cover a lot of teaching points and clinical issues that we encounter in these kind of cases. So why do we do this? So we have to understand why I'm talking about cases is because we first need to understand how do we make decisions in our clinics. And now it is well recognized that there is something called recognition prime decision making. So what we are doing in clinics unconsciously is this recognition prime decision making, which means how experts primed with previous knowledge and experience solve complex and high stake problems where there is issue of time. So you sometimes have to take quick decisions. For example, if somebody has got acute MI cardiogenic shock, he might immediately require angioplasty. So you have to take a quick decision whether you are taking him for angioplasty, whether you are thrombolizing, or whether you are doing nothing. So I think that kind of decision requires some time constraint also, and therefore this is recognition prime decision making. Now, basically, it's a dual process of cognition. We have to understand there are 2 kinds of thinking that are involved. First one is intuitive thinking, which is something what artificial intelligence also does. So it is basically identification of pattern, whether it is a demographic pattern, whether it is a pattern of symptom complex, whether it is a pattern of investigation, or whether it is an interrelation between these different patterns. So this kind of thinking takes very little time. It is mostly reflexive, and therefore wherever time is constrained, this kind of thinking is of extreme value. There is another kind of thinking that we often practice that is in difficult cases. And this is a slow, deliberate cognitive process. And the beginners use this to understand. And even experts use it sometimes when they come across with complex patient presentations where the pattern is not fitting completely. So very often we see cases where we cannot make out a distinct pattern, and therefore we are confused whether this is this or that, and you require to go through the differential diagnosis and then make your analysis. So when you start thinking of differential diagnosis, this is the type of analytical type of thinking. In reality, what we do is use both of them. If the pattern fits, then we go for intuitive thinking. But if pattern does not fit, then we identify groups of patterns and do analytically think what pattern is fitting best. So with this, I think I will move forward. What I wanted to tell you was that the more the experience the physician, the better. And I think this is a well-known fact that with experience, you become better in diagnosis. And this is because your intuitive thinking improves and you develop a library of cases in your memory bank. And once you develop this library of cases, and whenever then a pattern matches one of the things in your library in memory bank, you very quickly make a diagnosis, which is not only faster, but also much more accurate. And I think that is the importance of learning by cases, that you build this mental library, even if you have not done that case yourself. So others cases you can see to build your own library. And I think that is the whole point. Now, coming back to ADHF, we know that prevalence of heart failure is about 1 to 2% of all the adults. And particularly if more than 55 years, then prevalence of or incidence of decompensated heart failure becomes 1% per year. And so much so that about 7 per 1,000 persons may require recurrent hospitalizations. So 0.7% basically percentage. So you can see that practically all types of heart failure over a period of time may go into acute decompensated heart failure, and many of them requiring frequent admissions. The problem is that mortality, once that hospitalization with heart failure has happened, the mortality is huge and is actually in many cases much worse than most kinds of cancer. So the mortality is 10% within 1 month, about 30% within 1 year, and 42% at 5 years. So which is like worse than many types of even cancers. Interestingly, out of these heart failures, about it is 50-50 divided. 50% are because of reduced ejection fraction, and about bit less than 50% is because of preserved ejection fraction. So why do we do these cases in acute decompensated heart failure? Acute decompensated heart failure is especially useful to look at cases because there are complex interrelation between symptoms, pathophysiology, comorbidity, investigations, ultimately with treatment consequences. So that is why you need to make those patterns which will help you in making a diagnosis, understanding the prognosis, and finally treating your patients. Here, classical learning may fail to bring out these intricacies because there is so much interrelation or overlap between these different modalities that a classical learning by textbook may not be that useful, and therefore learning by cases which may be much better. So basically what I'm going to do is, if time permits and if Dr. Tapan allows, I will like to discuss 7 cases which will bring out these intricate interrelationships between various aspects of ADHF. I will show you how intelligent data analysis, analytical thinking leads to development of intuitive thinking by building the memory bank. So what I will do in these cases is analytical thinking. But what I'm hoping is that this goes into your memory bank, which will help you in intuitive thinking when time comes. What I will do throughout the course of presentation is ask critical questions during each and every cases. I will bring out the dilemmas that I faced while I encountered these cases. I will also discuss with you the mistakes that I committed while doing these cases, so that you don't have to commit the same mistakes. And I will keep reinforcing what we learned from each individual case. So the cases that I'm going to deal with or talk about is a classical ADHF case, a case who underwent guideline-directed medical therapy, but still ended up with recurrent ADHF. Third case is identify the cause. Fourth case is a common complication after usual drug treatment, that is developing a hyponatremia. The fifth case will be a case where we intervened with a device, but the device did not help. So that was a CRTD non-responder. Then I will also talk of another type of heart failure, which is not low output failure, but HFpF, which I said was about 50% of the cases. One of them is high output failure. And finally, one of the most dreaded complications of ADHF, that is development of cardiorenal syndrome. So these are the cases that I'm going to discuss. So coming to the classical case that we see every day, at least we see in our place, this is a 15-year-old girl who presented with class 3 dyspnea a week earlier, progressing to class 4 dyspnea when the patient presented. No history of fever, no history of chest pain. The vitals were a bit low, 90/60 pressure, pulse pressure of the 30. Pulse rate of 104 per minute, respiratory rate 24 per minute, oxygen saturation 92% at room air. So what we see is a adolescent girl with progressive dyspnea of recent origin, less than 3 weeks, without any fever or wheezing, with some hypotension and some hypoxia. So now the dilemma, of course, is that this girl is in trouble for sure. What we are wondering is what can be cause of this trouble in this particular girl, right? So this is the dilemma that we face, because we face with this emotional situation also of just 15-year-old girl presenting with this serious kind of illness, which we need to not only find cause, but also to treat this patient. So let us first look at what are the causes of dyspnea in young. Of course, some of the causes are like asthma could be there, heart failure could be there, pneumonia, bronchiolitis, anemia, pulmonary thromboembolism, and psychogenic. Here, looking at the overall picture, because the hemodynamics are also involved, looks like either it could be heart failure, or it could be even a case of anemia, which is a bit less likely, but heart failure seems most likely because it's a combination of hemodynamic compromise and along with dyspnea. So basically what we analyze is that there is evidence of shock with narrow pulse pressure, tachypnea, slight hypoxemia. So basically, as I said, seems secondary to primary cardiac failure. Pulmonary etiology is unlikely because otherwise pulmonary will be dominating with no hemodynamic compromise at this early stage of pulmonary compromise. So it is most likely cardiac with some involvement of pulmonary. Anemia could be a cause, as I said, but no, we don't find many cases where anemia can lead to shock. So then it also becomes unlikely. So basically, clearly heart failure is a cause, but we still cannot rule out anemia or pulmonary thromboembolism that can be superimposed upon heart failure, or even atypical pneumonia where it does not cause fever, which can be superimposed on heart failure. But heart failure diagnosis seems most likely at this stage. Now looking at cardiovascular examination, first sound present, second sound present, there was a present of third heart sound as well, but no murmur, and bilateral creps are present. So now what, after auscultation or after examination, what we find? Presence of S3, which confirms most likely heart failure. Absence of murmur tells you that probably no rheumatic heart disease. Bilateral creps shows you that patient must be in pulmonary edema. Hemodynamic instability also rules out a pulmonary etiology, and there is no respiratory localization, and second heart sound is not increased, which shows you that it is not pulmonary artery hypertension, which means this is of a very recent onset. It is not a old heart disease from left-sided going into right-sided. So this is a recent onset heart disease. So all these things we can find out with a careful clinical examination. So now to just analyze again, what could be cause of heart failure in adolescents? Valve disease unlikely because no murmur. Myocarditis seems very likely because at this age myocarditis can happen, but the only problem is that there is no fever, which generally myocarditis is associated. But remember, 50% of myocarditis have no fever. Congenital heart disease, etc., is also unlikely because there is no murmur. Generally, congenital heart disease at this age will give some murmur. Dilated cardiomyopathy is a possibility. Second possibility, but again, remember, it could not be ischemic because of young age, although some other causes can happen in adult. It could not be drug induced because there is no evidence of any drug intake. It could not be rhythm disturbance because there is no rhythm abnormality. It could not be muscle dystrophy because no muscle abnormalities. Also, restrictive heart disease could be ruled out because there is presence of third heart sound. So I think what we are left at this moment is only two possibilities, either myocarditis, most likely possibility, and dilated cardiomyopathy, a atypical type of dilated cardiomyopathy, as a second possibility. And other things, I think we can clearly rule out pericardial disease because of S3, pericardial tamponade also not liking, again because of S3, CCP unlikely, any pericardial disease unlikely because of presence of third heart sound. Then HOCM is also unlikely because it does not cause shock and pulmonary edema so common, and severe anemia, as I said, can cause high output failure, but it is a narrow pulse pressure, so which shows that it is mostly of cardiogenic origin with reduced ejection fraction, not increased ejection fraction. So anemia can be existing and can add to the problems, but it is not the prime cause of this particular problem. Now let us proceed further. Look at ECG. What ECG shows is sinus tachycardia, low voltage QRS, epiphysis access, P wave less than 2.5, that is no P pulmonale, and no significant STT changes or PR segment deviations. So basically, if you look at low voltage, what are the causes? Basically, the most common cause is a communication gap between the heart and the stethoscope. So could be because of excess air in the lungs, or some fluid accumulating somewhere, or a myocardium that is electrically inert. But also it could be because if there is very severe inflammation of myocardium due to myocarditis or some other cause that causes severe infiltration or inflammation. So also remember that ECG generally does not provide diagnosis, but is important to rule out. For example, a normal P wave rules out pericardial diseases in this particular case, and also rules out some other problems. For example, valvular heart disease also it rules out. So ECG, as I said, is more important in ruling out than ruling in. It rules out HOCM because low voltage. It rules out pulmonary embolism because there is no S1Q3 T3 pattern. It rules out pericardial diseases because the PR segment is not depressed. And it also rules out severe anemia because of these, because there is no ST segment depression, there is no LVH, etc. So I think ECG rules out so many conditions. So we are left with only myocarditis and DCM that were in any case our original diagnosis. Now look at X-ray. It is of course an over-penetrated bedside film. So not much can be connected. All we can say is that there is some cardiomegaly. So what X-ray also does is mostly rules out certain conditions. It does not rule in any condition, but it mostly rules out. What it rules out is pneumonia for sure. It rules out pulmonary thromboembolism. It also rules out pericardial effusion. It also rules out constrictive pericarditis. So again, what we are left with is either myocarditis or dilated cardiomyopathy. Now let us look at the routine investigations. Hemoglobin is 9. So we can see mild anemia. There is TLC, so bit of neutrophilia. Other things are okay, but sodium, potassium is low. You can see 3. Urea, creatinine are normal, but SGOT, PT are slightly raised. If you look at cardiac specific investigations, troponin is raised. BNP is markedly raised. Pay some attention. It is more than 8,000. So BNP is markedly raised. T3, T4 is also, TSH is also bit raised. So TSH is bit high. So that is another thing, positive finding. Other things are normal. So I think now we can make a diagnosis because the BNP, if you look at among all the data, if you look at BNP, which is so high, it practically confirms the diagnosis of advanced decompensated, acute decompensated heart failure. Mild anemia, as I already discussed, it's really 9 only, and that cannot explain the picture at all. Hypothyroidism is also present, but it is just subclinical because TSH is less than 10. And unless TSH is more than 10, we cannot think of a serious thyroid problem. It could be a component of low T3 syndrome that often happens in heart failure situations. There is also mild hepatic dysfunction, which we see could be because of, maybe if it is myocarditis, could be either viral myocarditis, or it could be because the hemodynamics of blood pressure is slightly reduced. So it could be because of hepatic dysfunction that we see because of hypoperfusion. So now I think we are pretty sure that our diagnosis is ADHF or acute decompensated heart failure. That is most likely. Somebody saying anything?
No, nobody saying.
Sorry.
Please carry on.
Okay, so why do I say ADHF? Number 1, progressive dyspnea without chest pain, ruling out coronary artery disease. Hemodynamic compromise out of proportion to respiratory compromise, making it a primary cardiac problem. Third heart sound present, meaning left ventricular failure. Bilateral cracks, meaning pulmonary edema. Cardiomegaly without pulmonary involvement. TLC indicating maybe it is some kind of inflammatory or infectious involvement of the heart. Raised BNP strongly favoring acute decompensated heart failure, and mild hepatic dysfunction could be a component of either congestion or viral myocarditis. So I think at this stage, we can safely rule out pericardial effusion or tamponade for several reasons. We also rule out dilated cardiomyopathy. Why? Because the progress is about 2 weeks. With dilated cardiomyopathy, progress is mostly more than 1 month. So this is a rather rapid progression. There are no ischemic or rhythm changes. There is no history of intake. There is no history of muscle dystrophy. So at this age, in a child with this kind of problem, dilated cardiomyopathy is also practically ruled out. But of course, confirmatory diagnosis is by echocardiography. Here, echo shows ejection fraction of 15 to 20%, LV, which is slightly dilated with moderate MR, but no mitral thickening, which shows you that it is probably secondary to LV dilatation and not because of primary valve disease. Moderate TR also secondary related to ventricular dilatation, and mild pericardial effusion, but no evidence of tamponade. So basically, how do we analyze? There is a gross LV systolic dysfunction because of reduced ejection fraction, but LV is not that much enlarged, which tells you that this is of very recent onset, because if it is a long onset, then LV will also be grossly dilated. But it is not grossly dilated, it tells you it is like it's clearly of very recent origin, most likely of myocarditis. Moderate MR is also present, but no thickening, which tells you RHD is unlikely, mostly secondary to dilatation, slight dilatation, and right-sided features seem to be because of left-sided abnormality, and myocardial disease can be, pericardial slight effusion could be there because of any serious cardiac problem.
I think one point that you said is very important, that in acute heart failure, if the LV is not increased much, it is of recent duration. That is a very important point.
Yes. But it is not diagnostic. The diagnostic test is cardiac MRI. And I think nowadays, with more and more conditions of these kind of complicated cardiac things, cardiac MRI should be the investigation of choice, especially in this kind of setting. And here cardiac MRI tells you that with adenosine, with contrast, tells you that there is some subepicardial scarring, which makes a diagnosis of myocarditis. So MRI is now the gold standard for diagnosis. And for diagnosis of myocarditis, there is a late Louis criteria with about 80% accuracy, and it helps in localization of injured tissue, including edema, hyperemia, and fibrosis, and should be carried out now in all cases before doing endomyocardial biopsy. What MRI shows you here is there is mild LV dilatation, which we could already see with echo as well, but not huge dilation. RV is actually normal in size. There is no evidence of myocardial edema or intramyocardial iron deposition, which can happen in some of the iron storage disorders. The patchy increase in signal intensity in myocardium, predominantly LV, and late gadolinium enhancement. This is, I think, key word. Late gadolinium enhancement shows patchy areas of subepicardial enhancement in basal, mid-inferior, inferior-lateral, and anterolateral segments, which is diagnostic of myocarditis. So diagnosis of myocarditis is clearly established with CMRI. So I think what is our next strategy? Of course, you need to prognosticate this patient, then you can give the proper treatment. So if you look at prognosis, a fulminant myocarditis with less than 3 weeks onset has got with very severe cardiovascular compromise or very serious symptoms is a bad prognosis. Mortality rate here is about 50%. And actually this patient is even sicker because the patient is not only fulminant myocarditis, but is already gone into shock with evidence of global hypoperfusion. Now we know that hepatic failure may be because of hypoperfusion itself and markedly raised BNP levels. So, and some comorbidities like anemia, subclinical hypothyroidism, and presence of hypopotassiemia as well. So actually this patient is even more sick than a classical case of fulminant myocarditis going into ADHF. And so mortality in this kind of patient would be in the range of, I would expect around the range of 75% if proper things are not done. So what was done now in this patient? A radial line was put for blood pressure monitoring. Very important to monitor blood pressure, because how do you treat this patient? of developing hemodynamic compromise, you measure mean blood pressure and you try to keep mean blood pressure ever more than 65. So that is, I think, very critical, that you try to keep mean blood pressure more than 65, and therefore you put in a ABP monitoring. The other thing that you monitor, because it's a case of cardiogenic shock, and in cardiogenic shock, CVP is not very important. In other kinds of shock, CVP may be important, but in cardiogenic shock, it is best to measure pulmonary capillary wedge pressure, which should be kept less than 14. Here, pulmonary capillary wedge pressure was found to be 18. So patient is very sick. Therefore, you cannot give IV fluids also in this patient, because you can give IV fluids only when pulmonary capillary wedge pressure is less than 14. So what was given was some inotropic therapy, which increases the cardiac function, because it's a case of cardiogenic shock. So cardiac function has dropped. So IV dobutamine was given and infusion was increased with attempt to keep systolic blood pressure above 100, and more important, mean arterial blood pressure more than 65. In this case, because pulmonary capillary wedge pressure is 18, we want to keep pulmonary capillary wedge pressure 14. So fluid restriction less than 1 liter fluid per day. Potassium was low, if you remember, 3. So potassium oral dose given. And because patient is congested, we know that because pulmonary capillary wedge pressure is 18. So instead of, rather than giving fluid, we would give diuretic. At a high dose, furosemide was given, repeated after 2 hours, trying to bring pulmonary capillary wedge pressure to less than 40. Then once blood pressure comes up to more than systolic pressure of 100, then we can start some other therapies like ARBs or ACE inhibitors. Also at that point, we can start some vasodilators, NTG, for example, but to make sure that systolic blood pressure remains 100. So 2-3 targets that we keep in mind: pulmonary capillary wedge pressure kept below 14, mean arterial blood pressure kept more than 65, systolic blood pressure kept more than 100. And then you tinker with the therapy. The fourth thing that you keep in mind is to keep oxygen saturation about 95%. And then what specific do you want to do? Since diagnosis of myocarditis has been made, so we have to give immunotherapy. And so IV immunoglobulins were given in this patient, 2 grams per day for first day. And then according to this, and also steroids. So remember, whenever there is a immunogenic cause, you can give steroids to modulate the immune response, and therefore these 2 things were given. IV immunoglobulin, I have to say, is a bit controversial, but this was a young girl, 15 years of age, who was clearly on a very bad course. So we decided to give immunoglobulin as well to this patient. So, but still there are several questions in our mind. If we have to use inotropic therapy to control shock, what drug should we give? Should we give dopamine, dobutamine, adrenaline, noradrenaline, bisoprolol? What should we give? How do we manage dyselectrolytemia in this patient? Should we give because sodium is also slightly low, 130. So should we give sodium supplementation, hypertonic saline, or oral salt? Or do we just be happy with fluid restriction? Can we supplement potassium? Do we give oral potassium or give IV potassium? Do we give Vaptans, which are also some of the therapies that you can give in case of dyselectrolytemia? So that is the thing. Then should we support with ventilation? Remember, it is 95% of oxygen saturation. Should we give oxygen by nasal prongs? Should we use non-invasive ventilation, CPAP, BPAP, or full mechanical support? Now, also important questions that come in mind is, should we give a thyroid supplement? Because remember, TSH was high. And how do we treat anemia? Should we give oral hematinics? Should we give erythropoietin analog? Should we give IV iron therapy? Should we give blood transfusion? Then should we undertake any other investigation? We have already done MRI, but do we need any other investigation like AIIMS, etc.? But I think most important thing that is in our mind is, have we done enough for the patient? Are we on the right track? So as you can see with this case, which we face daily practically in an advanced center, is this kind of picture, and which leads to more questions in mind than answers that we can generate. So as I said, it's a typical case where more questions are there than answers. So I think I will come back to this case a bit later, but I will navigate through other cases so that our understanding improves so that I think we can tackle this case at a later stage. So coming to my second case is one which I talk
about this case. Should we be sending some antibodies for Coxsackie, because Coxsackie is the commonest cause of valve myocarditis?
Yeah, I will come to that.
Okay.
I will come to that later, because this is, I will come back to the case. But before I think we go into the advanced management strategies of this particular patient, let us just look at the basic things first, so that we can move on to more complex things. So here is a case of guideline directed medical therapy, 75-year male Caucasian with already diagnosed case of non-ischemic cardiomyopathy 4 years back, with risk factors of hypertension, past smoker, CKD, ejection fraction 30%, with severe MR and moderate TR, already undergone repair, mitral valve repair for severe MR of dilated cardiomyopathy origin, non-valvular MR, but still MR was so much that it required valve repair. But despite all this, has presented with worsening dyspnea at this time, with blood pressure on the lower side, tachycardia, and respiratory rate 22 per minute. So I think first question that we need to address is whether it's a case of ADHF. So we know that heart failure is a syndrome of ventricular dysfunction. Also, we know that heart failure diagnosis or ADF diagnosis is not based on just one criteria. Clinical feature like edema, worsening dyspnea is just one, but we also need to look at X-ray for evidence of congestion, ECG, TTE or transthoracic echo will be more diagnostic, but the biomarkers will help, and sometimes we have to do even right-sided catheterization. However, the core of heart failure and advanced decompensated heart failure is generally congestion, which reflects increased cardiac filling pressures. So if we examine this patient, we find that the apex impulse is shifted laterally, which shows presence of LV dilatation. There is a palpable and audible third and fourth heart sound, again, serious LV involvement. Accentuated P2, which can happen in other causes of heart failure also, but more likely in reduced ejection fraction. Pansystolic murmur at apex, which shows that ventricular, probably due to ventricular dilatation. But more importantly, what we find here is that evidence of inspiratory basilar crackles, which shows you that person is in pulmonary edema, and dullness to percussion of breath sounds at lung basis tells you that probably there is some pleural effusion as well. So basically advanced cardiac failure, that is what it tells you. So of course we can do other investigations. We see that they help in making this diagnosis of ADHF, but there are some specific investigations that we need to do in many cases for ascertaining that this is a cardiac event. We need to look at cardiac markers. Troponin and BNP are very good. Troponin tells you of cardiac myocardial damage, and BNP tells you that it could be of heart failure origin. But in older individuals, we need to do either coronary evaluation also. But the diagnostic test again is MRI. But we can do other tests also, EMB and serological tests, as Dr. Tapan told, are also part of this whole investigation, where you look at various serological markers to identify various problems which could be related to viral myocarditis, which could be related to some diseases like even amyloid or sarcoid or some other diseases that can be picked up by doing different kind of serological, or myopathies you can pick up by doing different kind of serological tests. Sometimes you need PET also, and you also need to look at urine or plasma osmolality. But how do you teach the case with reduced ejection fraction? Number one is to identify the cause, because if you can identify the cause, you can treat it. The second principle is to manage, give a guideline directed medical therapy. I will talk about the guideline directed medical therapy. Third is, if patient is worsened, then you have to manage the ADHF as well. And then the things that come in management in case you cannot manage with drugs is either cardiac assist device or cardiac transplantation. So coming to the guideline directed medical therapy first. So first agent or the agent of choice, even in patients with heart failure, if they are hemodynamically stable, is beta blocker. In this case, we used bisoprolol, although you could use bisoprolol, metoprolol, or carbidopa, any of them. The second agent in guideline-directed medical therapy is either ACE inhibitor, ARB, or ARNI. Here we used ramipril. The third agent, because it's a congestive heart failure, so use diuretic. Generally, you could use loop diuretic or thiazide diuretic. Here we used Lasix, which is a loop diuretic. Then, in some cases, if patient does not improve, you could, if in use, mineralocorticoid receptor antagonist like spironolactone or aprilinon. If the patient still does not improve, then you can use ICD and CRTD. ICD may be used depending on looking at ejection fraction. Then vaccination is something we miss very commonly. I mean, this is not for acute patient, but for a chronic patient, because influenza worsens many of the myocardial problems. So vaccination is a good thing on long-term basis. And then some new drugs have come like gliflozins, dapagliflozin and dapagliflozin have also shown good response. But they are not probably the first line drugs at the moment. But what we need to understand is, how do we add on drugs, or how do we manage a patient of reduced ejection fraction if it does not respond to the classical treatment? So what are the principles? So first principle is, we can increase doses of these drugs, but a beta blocker dose can be increased only under the cover of diabetic. So this patient worsened, so we increase the dose of beta blocker, increase the dose of ramipril, but under the cover of increasing Lasix dose. Second thing is, if symptoms persist, then you can uptitrate further, but also add mineralocorticoid receptor antagonist, but under a diuretic cover. Here what we did was, ramipril, it was increased to 10 mg. Bisoprolol could not be increased because patient developed AV blocks, first degree AV blocks, but aprilinon was added. So that is the second state of treatment. But the symptoms still persisted. So now in a patient where you have added all these drugs, but symptoms is still persisting, what can you do? So the principle is to follow is that you can now consider giving a mechanical device like CRTD. From a drug point of view, what you can do is, you were already put on ramipril, maybe now you can shift to an ARNI, which would be superior to plain ACE inhibitor. And then, we can look if all the other GDMT can be uptitrated. So in this patient, what we did was, ICD can be given if QRS morphology is greater than 150 millisecond and there is presence of LBB. But here it was not like that. So ARNI was started, ACE inhibitor was stopped for 48 hours. Also remember, immediately after ACE inhibitors, don't start ARNI, because there could be cases of severe hypotension. You have to wait for 48 hours before you can actually start ARNI. So that was exactly done, and ARNI 100 milligram was started and increased to 200 milligram. Also, in this patient, dapagliflozin was started 5 milligram, increasing to 10 milligram. But unfortunately, there was another episode of ADHF. So all we did, and we increased the medicines, did everything, but the heart failure still happened and patient required hospitalization. So now the patient has had 3 hospitalization. We can call this patient as refractory heart failure with 3 hospitalization with ADHF with increased pro-BNP despite high dose Lasix. In the 3rd hospitalization, blood pressure was fortunately okay, 120/80. Heart rate was 60. SpO2 was 97%. X-ray, there was evidence of pulmonary edema, but a pro-BNP was 1689, again markedly elevated. Ejection fraction was relatively same with evidence of LV dilatation. And now I think it is a time when all this therapy you have given has not worked. So we need to do something more. And what is that something more? Either you give a cardiac assist device to temporarily bridge till cardiac transplantation can be done. So now this patient is a candidate for cardiac transplantation. For bridging this patient to making him survive till cardiac transplantation, maybe you can give a cardiac assist device. Unfortunately, what happened in this patient was, as often happens in patients in India, that this patient refused cardiac transplantation. So I think that was now a very serious problem. So what to do? So we did something which is a bit interesting. We decided to put a remote monitoring system to measure LA pressure. Remember, LA pressure or pulmonary wedge pressure, if you monitor completely, you can of course do pulmonary capillary wedge in hospital, but once patient gets discharged, you cannot do pulmonary capillary wedge pressure because you take out the Songens. So there is a device available where you can monitor the LA pressure and then change the diuretic dose according to what LA pressure shows. So that is exactly what we did. We got it from outside on a compassionate basis, put this device for measuring the LA pressure. And based on the daily measurements, we adjusted the diuretic therapy. And with this, actually, the patient improved markedly. And the quality of life indicators also improved. The diuretic dose was increased or decreased according to LA pressure. Practically every day in the beginning, then after in a week or so it was changed, and dose of spironolactone and furosemide was adjusted, and the patient survived. So I think, what did we learn from this case? Number one, guideline directed medical therapy is cornerstone for heart failure therapy. Number two, the aim to therapy is to reach the target dose and then initiate another therapy as required. But in ADHF or refractory heart failure, you would recurrent ADHF or refractory heart failure, you would need to consider heart transplantation, and in between maybe a cardiac assist device. In case you are unable to do this, then permanently measuring the LA pressure can be a good idea, and it can lead to optimizing diuretic therapy, which happened in this case. So I think what I will do at the end of this case is tell you what should be the algorithm for treatment of ADHF. First is, of course, because patient is in pulmonary edema, prop up the head. Then ventilation, if there is appearance of hypoxemia, if it is less than 90, then you will require ventilation. Morphine, diuretics like furosemide, add and step up ACE inhibitors, ARBs or ARNI, add ARNI as the case may be. Then vasodilators like nitrates can be used if pressure head is there more than 100. To increase contractility, sometimes you could add digoxin, which is not much used now, but most cases you would require a cardiac assist device. And then, of course, very important to identify the cause. In this case, the cause could not be identified, and because it was a progressive heart failure, a ischemic dilated cardiomyopathy kind of situation, and therefore the cause could not be identified and was basically just progression of disease. Therefore, no specific treatment could be attempted. But if you look, if you find kidney failure, then you can do therapy for kidney. If you find a correctable defect like coronary artery disease, you can offer bypass surgery or angioplasty. Valvular lesions, you can offer surgery. Acute MR, you can offer surgery. Ventricular aneurysm, you can do surgery. VSDs, you can do surgery. And ventricular assist device can be used to stabilize. But remember, if you use ECMO, then you cannot use it for long, because problem is that LV pressures keep rising. So you would require another device for LV venting, maybe another assist device. But I think final treatment is cardiac transplantation only. CVP comes down and the fluid rebalances, which leads to drop in mean arterial pressure. So unless you give some fluid in septic shock, the mean arterial pressure will not come up. So very cautious. But here the problem is that it is cardiogenic shock also. So obviously you have to keep a watch on CVP and also the pulmonary wedge if possible, but careful fluid resuscitation. 200 ml given first 30 minutes, then 500 ml given first hour, and about 2 liters given in the day one. And what fluid should you give? Ringer lactate, plasma light. Also you could give albumin, but then the second thing is, once you give fluid, anyway patient may be a bit congested, keeping a watch on pulmonary capillary wedge and also CVP, you have to give a diuretic administration also, because that will decrease the fluid load also, decrease the CVP also, and can cause clearing of congestion. Then inotropes, Or then the third step is to add vasopressor. Remember, when septic shock is a problem, I told you vasopressor is the best thing, and mean arterial pressure should be given more than 65. But here it is a cardiac shock also, so you have to give inotropes as well. So you have to give combination of vasopressor and inotropes, that is dobutamine, vasopressor, noradrenaline, epinephrine, vasopressin, I already told you, and high dose dopamine is also vasopressor. But in most cases, or in many cases, when nothing works, you have to give a mechanical circulatory support, and that may be life-saving, as we already saw in the first case. But if the patient is congested, means cardiogenic shock, but no septic shock, then you again have to consider the cautious fluid challenge. You have to see that the patient is congested, so very cautiously you give fluid. Diuretic administration is more important because the patient is congested, and again, vasopressors can be given, but inotropes are more important, and you can give other drugs also if it is a long-standing, as I said, if it is a long-standing cardiogenic shock, then you can give some things like milrinone and levosimendan as well. Here, in this case, it was a congested and cardiogenic and septic shock both, so this was not the case. I'm just talking of a hypothetical case. The third kind of case is non-congested but septic shock. Here you treat it predominantly as septic shock. So obviously here, because it is non-congested, so fluid giving is not a problem, but still give cautiously. Again, same kind of fluid therapy. Again, because it's a septic shock, vasopressors are the first line of agents. Then of course, inotropes. And finally, because to support heart, you could even consider a mechanical circulatory support. But if it is not a
non-congested means EF is low, but there is no failure as such.
Yeah, EF is low, patient is in ADHF, but not in cardiogenic shock, but septic shock. How do you find out? If you do a pulmonary capillary wedge, you find wedge is less than 14, and CVP is also less than 12. So you can say that, okay, patient does not have fluid overload, right? But patient has ADHF.
So there is no pulmonary edema and there is no hypertension, or there is hypertension in this patient?
Only borderline hypertension. Mean arterial pressure is more than 65.
Right.
Right?
Right.
Mean arterial pressure is more than 65. Systolic blood pressure is more than 100. Okay?
Right.
Then the last situation is when patient again has ADHF, but is non-congested and no shock. Then again, you can give fluid, vasopressors, and inotropes. So basically same kind of treatment. Now, coming to another interesting therapy, that is oxygen therapy, particularly NIV. Now, very important that to keep a good oxygen saturation, because remember, while perfusion had you achieve, you also require a good, the blood should have enough oxygen, because if oxygen is not enough, even if perfusion is normal, then oxygen will, then patient will suffer, the kidneys will suffer ischemia. So besides maintaining the perfusion, you have to maintain the oxygen saturation. Important thing is if saturation is less than 90 or PaO2 is less than 60, then oxygen therapy should be started with FiO2 200 till the SpO2 becomes 95. But remember, saturation more than 95 of oxygen is also harmful, because that can lead to decreased coronary flow, decreased cardiac output, and decreased cerebral flow because of vasoconstriction. So ideal is to maintain a saturation of around 95%. What I've seen is people keep giving oxygen 100% also, and that can be harmful because it will decrease perfusion to important organs. Coronary it will decrease, so cardiogenic shock will worsen. Brain it will decrease, so there will be confusion starting, and that will be harmful for the patient overall. So keep saturation around 95%. I hope I have made this important point. What is the indication of giving NIV? Of course, when SpO2 falls less than 90 on oxygen, when respiratory rate is more than 25 despite oxygen, then you can give NIV. It will improve symptoms. It will decrease the need for intubation. Also, it will decrease mortality. But contraindication is if blood pressure drops. If systolic blood pressure drops less than 100 or less, or if mean arterial blood pressure drops less than 65, then it is time to intubate. or if there is a respiratory arrest, or if there is a decrease in consciousness, if there is pneumothorax, if there is vomiting, etc., then I think it is time to intubate the patient. So already I have given the final note. So I think I will end with this. Thank you so much. I hope this was helpful to at least some people.
Thank you, sir. That was very nice. Please stop the share screen, sir.
Okay.
So very nice cases, sir, and a lot of learning for all of us. So one question came up from the audience. Can we use CRT for LBP?
LBP, yes, this is where it is used. With low ejection fraction, if LBP is present, then there is benefit of CRT.
So then, what is your experience with the levosimendan? Where should we be using levosimendan? It is it has come up and some people are using it, but what clearly are the indications or in your experience where it helps?
Basically, the thing is that if you require a lot of vasodilatation, and that vasodilatation you are unable to achieve with nitroglycerin, then I think you can add on levosimendan. And then it can help, but again, keep in mind that systolic blood pressure should be more than 100 and mean pressure should be more than 65.
So definitely,
since CVP is high and you are unable to control with IV nitroglycerin, then the options that you have is you could use levosimendan or you could go for ultrafiltration. Because if you don't have this or you're not experienced with it, then you can use ultrafiltration to remove some of the extra fluid to bring down the CVP. Because remember, the mean arterial blood pressure minus CVP is the perfusion pressure to the kidney. So if CVP is rising, then perfusion pressure to kidney is declining, and then there could be renal failure. So this is a point where you have to, whatever way you do, you have to bring down the CVP. Restrict fluid, give diuretics, give vasodilators. Diuretic, you give first loop diuretic, then you give IV diuretic. Then even if it does not work, then add on another maybe diuretic. Still does not help, then use vasodilators. IV nitroglycerin still does not help. Then the option you have is ultrafiltration or use of levosimendan if you don't want to do ultrafiltration.
Yes. So then just one last question. You must be tired also. So in the definition of cardiogenic shock, everywhere they write that the SBP should be less than 90. And if for a septic shock, actually,
it should be less than 90 for more than 30 minutes with evidence of organ dysfunction.
Right, sir. So, exactly. So, but for septic shock, we take it as mean arterial pressure of 65. So, is there any significance to this, distinction which is made out that we use systolic pressure as a cutoff for cardiogenic shock, and we take the map in the septic shock?
No. The difference between cardiogenic shock, if you say one word, then it is measurement of pulmonary capillary wedge pressure. Because in cardiogenic shock, pulmonary capillary wedge pressure is more than, let us say, 15. It could be more than 18. If pulmonary capillary wedge pressure is more than 18, then it is cardiogenic shock. But if CVP is more than 12, then it could be cardiogenic shock. But if CVP is 0, pulmonary capillary wedge pressure is less than 14, still patient is in shock, then it could be septic shock. If it is mixed, then a mixed shock.
So no, we should not make too much out of the fact that we use systolic pressure of 90 for the definition.
Systolic pressure can fall because of both.
No, I'm just saying that they use systolic, but the definition is systolic pressure less than 90. What for septic shock?
No, same for septic shock also, but septic shock also the same thing. It is basically a definition for shock.
Okay.
Septic shock also pressure of less than 90 for more than 30 minutes. This is definition of shock.
Right.
You have to decide whether it is of cardiogenic origin, or is it of septic origin, or is it could be because of hypovolemia as well.
Right. Okay. Thank you, sir. There are no more questions. Thank you very much. So nice of you. Very nice session. And thank the audience. Thank you very much.
Thank you. Thank you.